Hello, my name is Lorrene Ritchie. I'm the director of the Nutrition Policy Institute at the University of California, and I'm going to be talking today about transition from breastfeeding and complementary feeding to toddler nutrition and childcare. For nearly 2 decades, we at the Nutrition Policy Institute have been using research to inform nutrition policy in the U.S. For example, we've conducted a series of surveys of representative statewide samples of children, allowing us to pass the first comprehensive beverage standards for childcare in the nation. But a barrier we have encountered is policymakers and program administrators concerned that standards would be too difficult for childcare, especially for family childcare home providers. In the U.S., licensed facilities can vary from small family childcare homes with a single provider and a few children to large centers or preschools with a director, multiple teachers, and several hundred children. Family childcare homes are particularly susceptible to having limited resources and nutrition information. And while relatively few studies have been done of them, the studies that have been have shown that they tend to have less optimal nutrition than centers or preschools. Of note, about a third of children are cared for in family childcare homes in the United States, especially lower income children. So while the concern is justifiable that nutrition standards may be too difficult to implement, there are plenty of reasons to ensure optimal nutrition in these settings for the welfare of children. So what I will be sharing with you today is a process we use to develop and test the feasibility of nutrition standards designed specifically for family childcare homes, in the hopes that we can inform nutrition policy in the United States and that others can adopt similar in their countries. As maternal employment has increased in the United States, so too has the use of formal state licensed childcare. Currently, about 2/3 of women who have young children are employed outside of the home. Childcare is important for nutrition for several reasons. It represents the largest institutional setting of young children, where they receive up to half of their daily nutrition and establish their nutrition habits. Over 1 in 5 children in the United States already start school overweight or obese, pointing to the need to begin obesity prevention earlier. And finally, while studies have found mixed associations between attending childcare and child obesity, more time spent in childcare early during the infant to toddler transition has been associated with obesity risk. So what we did was develop a standard, because there are no federal guidelines that apply to all child care settings. The dietary guidelines for Americans, they're updated every 5 years, and they're used as the nutrition Bible, so to speak, for nutrition programs in the United States. They do not include 0 to 2-year-olds and won't until the next iteration. There is a federal program called the Child and Adult Care Food Program that applies in the United States to child care. However, only about 1/3 of licensed child care facilities participate in this voluntary program. And further, the standards do not regulate foods or beverages that are not claimed for reimbursement and do not specify feeding practices. In addition, state level requirements are incomplete and variable, inconsistent with each other, and few states have comprehensive standards. So we worked with a panel of child care and nutrition experts to develop nutrition standards that fall under 2 categories: what to feed, the food groups, for example, beverages, grains, sugar, salt, etc., and how to feed, introducing solids, healthy feeding practices. We also developed nutrition standards for 2 age groups, infants and toddlers. I don't have time to share with you all of them, so I'm going to focus on toddlers, but the paper that will accompany this presentation will include the infant ones. We started with authoritative sources, the Academy of Nutrition and Dietetics, American Academy of Pediatrics, and others, and ended up with about 200 different standards that we then shared with our science and practice-based advisors, the names of whom are in the supplementary tables in the article as well. We used the Delphi type process, where experts discuss and then are asked to independently evaluate and rank the impact and feasibility to ultimately arrive at a group consensus. First, an expert group of nutrition scientists reviewed and discussed the recommendations from authoritative bodies and decided collectively upon a comprehensive set of nutritionally ideal standards. The nutrition scientists then independently ranked them on whether they were high, medium, or low impact for child nutrition and obesity prevention. Next, the standards were reviewed and ranked by impact by a child care advisory group. These experts were familiar with family child care home operations, and they were asked to discuss the relative ease in terms of time and cost to providers of implementing each of the standards. They were then asked to independently rank the standards on a scale of high, medium, or low ease of implementation. We then tiered the standards and based on whether they were high impact versus lower impact and less and more difficult to implement. In terms of evaluating the standards, we recruited a sample of 30 family child care home providers in California. Each provider received a brief training, which included information materials in advance on the standards, followed by a 2-hour in-person class. And the class was delivered and the materials were available in both English and Spanish. The training materials and in-person class were kept as short as possible based on our advisors' recommendations that family child care homes had little time for training. An assessment included a self-report survey of practices difficult for providers, difficult for researchers, that is, to observe, and a half-day observation of 1 meal and 1 snack prior to the training. At the training, we also shared with providers a list of which standards they were not doing at baseline and asked them to look over that list and pick 3 to 5 of those to work on over the next 3 months. We then repeated the assessment and compared the pre and post changes using paired T tests. This slide shows the characteristics of the study sample. Most participated in the child and adult care food program, took care of on average 7 young children, 63% were Hispanic, and 70% had at least some college education. Next, I turn to findings from our baseline evaluation on compliance with the nutrition standards. And what you can see is that prior to receiving the training, on average, providers were compliant with a good number of the standards, 59% in all. And we didn't observe any differences by tiers, a trend we also observed at follow-up. So our first lesson was perhaps we didn't need the tiering after all. On average, providers were compliant with more of the standards relating to what to feed children, the foods and beverages needed, as compared to the feeding practices. And this we also continued to observe after the training, suggesting that feeding practices may require more training for providers. While we did see differences while we did not see differences between the tiers, we did observe some standards that were already being done by a majority of providers. And while one would want to confirm this in a larger sample of providers, our data do suggest that some standards may be very feasible for homes to implement without much additional training or support. Examples of standards that were already being implemented by a majority of providers in our sample are shown on this slide. The next slide shows, in terms of feeding practices, the standards most providers were in compliance with at baseline. Again, showing some that probably providers don't need as much training in order to implement. How did the providers comply with the standards 3 months after the training? Well, we observed increases in compliance with 25 of the 37 nutrition standards. This is the tier 1 and tier 2 combined again. Differences were significant in 9 of these individual standards. And when we looked at the standards combined, compliance increased from 59% of the standards at baseline to 70% 3 months later, a difference that was significant. The 12% increase in compliance for food and beverage standards and the 9% increase in compliance with the feeding practice standards was also statistically significant. So next we wanted to examine how did providers do after the training for standards for which they were relatively non-compliant at baseline. And first we examined compliance with what was served, and we saw, for example, a 7% increase in providers who served no more than one serving of 100% juice per day, all the way up to a 100% increase for those who served only non-dairy milk substitutions, nutritionally equivalent to milk, such as soy milk. Increases in the range of 10 to 20% were observed for a number of standards, including for deep fried vegetables, usually French fries, yogurt, fruit, foods high in added sugars, white grains, milk, processed meats, and oils. And we also saw higher pre-post training increases for serving naturally low or reduced fat cheese and no cheese foods or spreads. In terms of compliance for how foods were served for those standards that weren't very readily implemented at baseline, we also observed various degrees of increases in compliance. But I highlight in particular those in red on this slide, as these are the ones for which few providers were compliant at baseline and only a small increases were observed after the training. That suggests that family child care home providers may need more support to implement family style meals and not pressuring children to clean their plates. Finally, there were a number of standards where we didn't see much change at all and even some decreases after the training. And the ones in red are particularly notable as none of the providers were compliant with them at either baseline or follow-up, again, suggesting that all of this list are things people may have more difficulty implementing. And several of them related to serving water and the anticipation of how little children learn to eat are ones that providers may need even more assistance with. Finally, because costs were a concern for family child care providers, we asked a number of questions about the cost of implementing these standards, and we found that about a third said that the cost of foods and beverages increased. Providers mentioned buying more fruits and vegetables and different kinds of milk were the main contributors to that increase in cost. 23% of providers said the cost associated with food preparation supplies increased, such as for purchasing child-sized plates and cups, one of the feeding practices included in our standards. And then importantly, we examined the time that it took for providers to implement the standards. Over half said it took them more time. On a positive note, however, about half of those said that as they got used to the new standards, the time it took decreased. These findings, however, suggest that providers may need additional resources to adopt and sustain the implementation of nutrition standards. I want to end by sharing a few implications of this work, both in terms of research and practice and policy. We concluded that infant and toddler nutrition standards have the potential to impact young children in childcare in the U.S., and that our preliminary results suggest that there is a great deal of feasibility for family child care homes to implement nutrition standards, but the next step is to test the impact on children in a larger randomized control trial of family child care home providers. We also learned that there was no need for the tiering and that perhaps standards could be incorporated in training and technical assistance for providers and into child care site policy. And eventually we hope to inform statewide policy as well as federal policy so that there are nutrition standards across the country for family child care home providers. I'd like to end by thanking the funder for this project, the David Lucille Packard Foundation, as well as my colleagues who contributed to this work, and I thank you for your attention.